The anatomy and physiology of lacrimal system, causes of epiphora, how to evaluate epiphora, acquired obstruction and congenital obstruction, acute dacryocystitis. These are the topics of our lecture today. The lacrimal drainage system consists of the following structures: the puncta, the canaliculi, the lacrimal sac, the nasolacrimal duct. The puncti are located at the posterior border of the lid margin, so it becomes in contact with the ocular surface. It is located at the junction of the pars ciliaris with the pars lacrimalis. We have two puncti, superior and inferior. The superior on the upper lid margin and the inferior on the lower lid margin. The canaliculi are the extension from the puncti. The canaliculi usually are 10 millimeter in length, each one of them, the superior and the inferior, and consist of two parts: the vertical part, which is about 2 millimeter, followed by the horizontal part, which is about 8 millimeter. The superior and inferior canaliculi join into the common canaliculus, which opens into the lateral wall of the lacrimal sac. We have a Rosen-Miller valve, which is a fold of mucosa that cover the junction of the common canaliculus and the lacrimal sac. The importance of this valve to prevent the reflex of tear from the sac into the canaliculi. What about the lacrimal sac? Is about 12 millimeter in length, and as we said, the common canaliculi open into the lacrimal sac. The situation of the lacrimal sac usually located in the lacrimal fossa between the anterior and posterior lacrimal crest. Beneath the lacrimal sac, we have the lacrimal bone and the frontal process of the maxilla. During DCR, dacryocystorainostomy, this is a common procedure in ophthalmology. We create an anastomosis between the lacrimal sac and the nasal mucosa to bypass an obstruction in the nasolacrimal duct. What is the nasolacrimal duct? Is the downward continuation of the lacrimal sac, is about 18 to 12 millimeter in length. It descends, and the direction of its descent is important because it takes an angle that's downward, posterior and lateral. So it goes downward, posteriorly and laterally, and opens into the inferior nasal meatus. The opening of the nasolacrimal duct by the valve of Hasner is very important. The terminal end of the nasolacrimal duct is covered by this thin mucosal fold, which we call it the valve of Hasner, which is partially covered by it, not completely, and imperforated valve of Hasner after birth is the main cause of congenital nasolacrimal duct obstruction. This picture shows you the anatomy. The tear usually originated from the lacrimal gland, flow onto the ocular surface and circulate with each movement of the eyelid. The eyelids usually during opening and closure redistribute the tear film over the ocular surface to protect the ocular surface and nourish it. Then the tears come to the puncti, upper and lower puncti, and drain into the nasolacrimal through the nasolacrimal duct after passing into the canaliculi, the lacrimal sac, and then into the ducts to the nose, into the inferior meatus of the nose, the opening of the nasolacrimal duct. We see the anatomy, the superior inferior canaliculi, then the lacrimal sac, and the nasolacrimal duct. What is epiphora? Epiphora is an overflow of tears at the eyelid margin. Usually we have two mechanisms for any epiphora you encounter during your practice. It's either hypersecretion or defective drainage. Hypersecretion can lead to an ocular surface disease like an inflammation, infection, irritation, or dry eye. In dry eye, we also have paradoxical watering and epiphora. What about defective drainage? Defective drainage due to an obstruction along the pathway of the lacrimal drainage system, which is either due to malposition of the lacrimal puncti. We said the lacrimal puncti are situated at the posterior lid margin so that it will become in contact with the ocular surface. But if this lid margin is malpositioned or the puncti is malpositioned, this will cause defective drainage. That means the puncti are not in contact with ocular surface, so how the tear will flow through them? The tear will not flow, and this will result in epiphora. So as we said, punctal malposition or malposition of the lid margin, ectropion, lacrimal pump failure. What we mean by lacrimal pump failure? In patients with facial nerve palsy, there is weakness of orbicularis oculi muscle, which is supplied by the facial nerve, and this will result in lower lid laxity and weakness of the lid structure. This weakness will result in lacrimal pump failure. Obstruction at any point along the drainage system also is a cause of defective drainage. So, defective drainage is either due to malposition of the puncti or the lid, or due to defective lacrimal pump system in facial nerve palsy, or due to any physical obstruction at any point of the drainage system, from the puncti to the valve of Hasner. These are the causes of epiphora. Evaluation of epiphora is important. We can do this simply by history, external examination, fluorescein disappearance test, and lacrimal probing with irrigation. History. What's the importance of history? We can ask the patient simple questions about any ocular discomfort, any redness, any itching, any irritation in the eye. This might indicate a cause of an ocular surface disorder and hypersecretion pathology for epiphora. What about drainage failure? We can ask the patient about any exacerbating condition for epiphora. Does it increase with cold, with windy environment? What happens in a dry room? Usually if there is a drainage failure, the condition is exacerbated by cold, windy exposure, and it will be least in any dry, warm environment. How about external examination? We can examine the patient from the first look to see if there is any lid malposition, which is ectropion, and then we go to the slit lamp to examine the lid. We see the puncti, there is any obstruction in the puncti, any pathology regarding the puncti, any lid inflammation, and we can do simple test, fluorescein disappearance test. What we mean with this test? This test is performed by installing fluorescein. Fluorescein usually is available either as a strip or as a tear substitute in a concentration 1% or 2% drops. We instill these drops into the conjunctival sag. Normally, there will be disappearance of this dye from the eye after 5 or 10 minutes. When we come after 10 minutes and examine the ocular surface and we see a remnant of fluorescein, this means there is a prolonged retention of this dye, and this indicates inadequate lacrimal drainage. Lacrimal probing and irrigation is the last step in evaluation. After we complete history, external examination, slit lamp examination, fluorescein disappearance test, we go for lacrimal probing and irrigation. In this picture, you see the lacrimal puncti. This is normal lacrimal punctum. It is situated at the posterior aspect of the lid margin, as we see, in contact with ocular surface. طبعا the lid here is inverted so that we can examine the puncti. It's very small, you barely can see it with bare eyes. This is the fluorescein disappearance test. We instilled fluorescein in both eyes. Then after 10 minutes, you see the right eye still contain fluorescein. This blue light, we call it cobalt blue filter. We use it to activate fluorescein so that any remnant of fluorescein will appear in this color, green color. Fluorescein is a special dye. When exposed to blue light, will turn into a green color while its true color is orange. So the right eye has defective lacrimal drainage while the left eye doesn't have any fluorescein remain. This is fluorescein disappearance test. This picture, in comparison to the first one I showed you, there is no lacrimal puncti. This is punctal atresia. Lacrimal probing and irrigation is the last step to evaluate any epiphora and to detect any lacrimal drainage obstruction. Local anesthetic is used, topical drops, punctal dilator. We use special instrument to dilate the puncti. As we saw, the punctum is very small, so we temporarily dilate them to insert lacrimal cannula, which is a special instrument inserted into the lacrimal pathways with a saline filled syringe. We insert it either through the lower punctum or the upper punctum. After the punctum, we stretch the lids laterally so that we can pass this instrument into the canaliculi without injuring them. After the canaliculi, from the anatomy, we will become in contact with the lacrimal sag and enter the lacrimal sag. Of course, if the upper system is patent, this will happen. What we will feel hard stop if the lacrimal sag is entered. When we enter the lacrimal sag, we will hit the bone, so we feel a hard stop. If there is obstruction in the canalicular system, we will not enter the lacrimal sag, and we will hit the lateral surface of the lacrimal sag. Because we are not entering inside the sag, we will hit the lateral surface of the sag, and the lateral surface will become pushed against the medial surface of the sag, the medial wall I mean. This will give us a soft stop. So soft stop means we are hitting a soft tissue, while hard stop we are hitting a bone. That will give us an impression whether there is an obstruction in the canalicular system or not. If we entered inside the sag and we had a hard stop feeling of a bone, we will gently then push the syringe and to see if the patient can feel the saline taste in his mouth. The syringe is filled with saline usually, so that the patient can give us an idea whether they feel the saline taste in their mouth or not. If the patient can feel it, this means that also, in addition to the canalicular patency, we have patency of the nasolacrimal system and the lacrimal sag. So it's a two-phase procedure. We first introduce the probe inside the lacrimal sag. If the probe entered the sag, this will give us a hard stop. After that, we will push the saline to see if there is any obstruction in the lower system. But if the probe did not enter inside the lacrimal sag, this will give us a soft spongy feeling. Here, if we push the saline, the fluid will come from the lacrimal canalicular system and the puncti itself, so it will reflex back because there is an obstruction in the lacrimal sag. If the patient cannot feel the saline, in a case we had hard stop and we pushed the saline after that, and the patient did not taste any salty fluid in their mouth, this means we have an obstruction in the lower system, which is the nasolacrimal duct. It's simple, but you need to understand it. It's a two-phase procedure. We enter the sag, then we push saline. If we don't enter the sag, we don't need to push saline because the saline will come through the puncti itself. This is lacrimal probing and irrigation. We see we use lacrimal probe or cannula. We enter through the vertical canaliculi first, then we push the eyelid laterally to stretch the horizontal canaliculi. The probe will also enter through the horizontal canaliculi. After that, it will pass through the lacrimal sag if the canalicular system is patent. If the canalicular system is not patent, the probe will not enter the sag. It will hit the lateral wall of the sag and will push it against the medial wall, and we will have the soft stop feeling, which is a spongy feeling. But if the probe entered the sag, this will give us a hard stop feeling. In case of hard stop, we can complete the test by pushing saline through the remaining sag and nasolacrimal duct to detect any obstruction in the lower system. This picture will show you what we mean with a hard stop and soft stop. Hard stop, the lacrimal probe, which is the red instrument here, is passing through the sag and hitting the bone beneath the lacrimal sag, while in the second picture the instrument is pushing the lateral wall of the lacrimal sag against the medial wall, and we feel a soft stop. Here, if we push saline in the second picture, the saline will come from the upper canaliculi. But in the first picture, which is the patent lacrimal sag, if we push saline, the saline will go downward, and the patient either will feel the salty substance in his mouth or will not feel it. This depends on the patency of the lower system. What about acquired obstruction versus congenital obstruction? Acquired obstruction is either a conjunctival chalasis or primary punctal stenosis, secondary punctal stenosis. Causes of acquired canalicular obstruction and acquired nasolacrimal duct obstruction. These are the causes of acquired obstruction. The first one is conjunctival chalasis, which means there is redundant fold of conjunctiva prolapsing over the lower lid margin and interrupting the tear from reaching the puncti. So this is very clear. The conjunctiva is swollen and intervening between the lid margin and the ocular surface. Here the stain is Rong's Bengal. We use it to stain damaged ocular surface. The remaining causes of acquired obstruction are either punctal stenosis, which could be primary or secondary, or obstruction in the canalicular system, or in the nasolacrimal duct. So any site of the lacrimal drainage system can be the source of obstruction, either the puncti, the canaliculi, or the nasolacrimal duct. These are the causes of each type, which is very important. Secondary punctal stenosis versus primary punctal stenosis. You need to know if there is any punctal eversion, ectropion, we call punctal stenosis as secondary. But if the lid is in normal position and the puncti are in normal position, there is no lid eversion, there is no ectropion, we call it primary punctal stenosis. That's the difference between the two. Of course, the causes are very clear here. You can understand them. I don't need to explain them. But you need to know the difference between primary and secondary punctal stenosis, which is the lid position. Acquired nasolacrimal duct obstruction. These are the causes of this condition. This happens in adulthood, usually due to either idiopathic stenosis, some unknown cause of stenosis, or any nasoorbital trauma, including nasal and sinus surgery. Granulomatous disease can cause acquired nasolacrimal duct obstruction, such as sarcoidosis, or tumor, nasopharyngeal tumor infiltrating through the nasolacrimal duct. Treatment usually here is DCR, dacryocystorynostomy. We have no other option. DCR, either the conventional or the endoscopic type. Conventional, this means we create an opening through the skin near the nose, and we enter to create an anastomosis between the lacrimal sac and the middle meatus of the nose. Success rate in conventional surgery is over 90%. But endoscopic type, success rate is lower, and we use a light pipe pass through the canalicular system and endoscope through the nose to do the same procedure without creating a skin incision. In conventional, we use a skin incision and direct approach. In endoscopic, we use an endoscopic approach from within the nose. That's the difference. As we know, the difference between these two procedures are the rehabilitation, blood loss, and expensive machinery. Congenital nasolacrimal duct obstruction is one of the most important subjects related to lacrimal drainage system. The lower end of the nasolacrimal duct in the region of the valve of Hasner, as we mentioned early in this lecture, is the last portion of the lacrimal drainage system to canalize, with complete patency mostly occurring soon after birth. In some children this will not happen. The percentage is about 20% of neonate. Canalization will not happen in this region of valve of Hasner, the terminal part of nasolacrimal duct. This will result in congenital nasolacrimal duct obstruction. But in over 85% of these neonates, by 9 months, 1 year, they will spontaneously canalize. Evaluation of this condition: epiphora and matting of the eyelashes, which could be unilateral or bilateral. If the condition is more severe, we expect it to be bilateral. This matting and epiphora could be constant or intermittent. The family comes to you with a unit complaining of this type of epiphora, which is either constant or intermittent, bilateral or unilateral. Might be sometimes associated with infection of the conjunctiva, and sometimes it is exacerbated after upper respiratory tract infection also. These are the common complaints. You need to know that. Simple test can show you that this child probably has congenital nasolacrimal duct obstruction. Gentle pressure over the lacrimal sag area will cause a mucopurulent reflex from the puncti. So if this happens, this child definitely has congenital nasolacrimal duct obstruction. You need to exclude any underlying possible differential diagnosis in cases of epiphora in a unit, which could be congenital glaucoma, keratitis, uveitis. I will explain these to you in the next slides. So normal visual function should be confirmed by anterior segment examination, intraocular pressure assessment, and red reflex examination. In any case of suspected congenital nasolacrimal duct obstruction, what is the differential diagnosis of watery eye at birth? I mean at birth in the first month, at birth truly in the first 2 months. So, yeah, it's not necessarily in the at birth, at the moment of birth. Conjunctivitis, congenital nasolacrimal duct obstruction, keratitis, uveitis, punctal atresia, or congenital glaucoma. So any child with epiphora, any infant with epiphora, we need to assess with anterior segment examination, proper center, to exclude any possible underlying infection or uveitis or congenital glaucoma. Congenital glaucoma can present as epiphora. Okay. What about the treatment of congenital nasolacrimal duct obstruction? Simply we teach the parents a special type of massage for the lacrimal sag. This massage will create a positive hydrostatic pressure that will rupture this terminal membrane. In many children, the massage is the only necessary treatment. Of course, this lacrimal sag massage is temporary measure. If it ruptures the membranous obstruction, then everything is fine, but the definitive treatment is probing and not the nasolacrimal massage. So it's a temporary measure because we cannot admit a child of 2 months or 3 months to the OR and do lacrimal probing under general anesthesia. Probing is a passage of fine wire via the canalicular system and nasolacrimal duct to disrupt the obstructive membrane at the valve of Hasner. This is the definitive therapy, but we can do it only after the child is 12 months old. So, while awaiting for surgery, the child should be given a lacrimal sag massage. This in many children will be very enough to open the obstruction. If this didn't happen, we go for probing. This massage can be done with the index finger applied over the lacrimal sag to occlude the common canaliculus. Then we passes downward on the nose with a pressure to obstruct the membrane. If a probing failed, usually happen if the child comes to you very old, above 18 months, usually the success of probing is negligible. You need to know that probing should be done from the age of 12 months to 18 months only. After this, probing will be unsuccessful. If a probing failed, we might need to intubate the lacrimal passages with silicone tube and leave them for 6 months, or we do DCR for a child. So it's very important to proceed according to the time schedule with the probing by age of 12 months, because if you neglect probing at this time, you might need DCR in older age. Acute dacryocystitis is an important subject you need to focus on. Presentation usually with subacute onset of pain in the medial canthal area associated with epiphora, very tender, tense, red swelling at this region, sometimes end up with abscess, sometimes end up with a preseptal cellulitis, which is infection of and cellulitis of the soft tissues. Treatment usually with warm compresses to decrease the pain and tenderness, and oral antibiotics. We don't do irrigation, we don't do probing, we don't do any type of procedure while there is an active infection. We give warm compresses, oral painkiller, oral broad spectrum antibiotics. Then if the pus collect, this means abscess form, and we see a white collection of pus, we can drain this pus only in this condition. After the infection is settled, the definitive treatment is with dacryocystostomy. This is acute dacryocystitis. We see the swelling, the redness, the discharge, the edema. There is even a cellulitis. Preseptal cellulitis is also present here. Treatment is warm compresses, broad spectrum antibiotics, and referral for ophthalmologist. This is acute dacryocystitis with abscess. This is an abscess collection. We need to drain this abscess, of course, with antibiotic cover.